Good evening. Welcome to tonight's seminar, Advances in the Natural Treatment and Management of Small Intestinal Bacterial Overgrowth. Our presenter this evening is Dr. Nirala Jacobi. Dr. Jacobi received her doctorate of naturopathic medicine from the esteemed Bacterial University of Seattle, Washington in 1998. 2 years ago, she founded the SIBOTest, an online testing provider for the accurate assessment of SIBO. In January of this year, she was invited to take part in the Delphi panel to discuss the developing field of SIBO treatment at the first SIBO symposium in Portland, Oregon. The panel included Dr. Mark Pimentel, Chief Gastroenterologist at Cedars-Sinai. Dr. Pimentel is a primary SIBO researcher and the author of the numerous scientific publications in the field of SIBO. Nirala herself is considered an expert in the natural treatment of SIBO and has presented on SIBO in past webinars. For some of you, these webinars were the first introduction to this condition. Hopefully this evening we will have time for question and answers at the end of the presentation. If for some reason we are unable to address them all this evening, Dr. Jacobi will email attendees the remaining question and answers in the coming week. Thank you for joining us tonight, and let me hand it over to Nirala.
Thanks, Jen. I'm really excited to be presenting this webinar tonight, and I want to thank you all for taking the time out of your busy schedule to learn more about this fascinating condition. I really think you will be glad that you did, because you will get a lot of information that you can put into practice from the get-go. SIBO, when I first heard about it about 3-4 years ago, completely revolutionized my practice, because like many of you out there, I felt like I really had a handle on digestive disorders, and I knew I would get a really large percentage of my patients improve straight away. And there was always a subset of people that, no matter if it was a treatment for candida or parasites or digestive deficiencies, were just not improving. And when I first attended a lecture with Dr. Alison Siebecker back 3-4 years ago, I was just completely flabbergasted that I'd never heard of this condition. So it was a light bulb moment for me, and I focused a lot of my time on researching this condition ever since. I think that you'll find it pretty relevant to what you can treat in your practice tomorrow morning. And for those of you who have attended previous webinars, this webinar focuses on the recent developments in SIBO and will introduce our new and revised treatment plan. So don't think that that we're going to rehash a lot of material from previous webinars. What we will be doing is, again, just a brief review. What is SIBO? Then we'll focus on new insights, SIBO and autoimmunity. We'll talk a little bit more about methanogens, which are methane-producing bacteria, a really fascinating organism. And then also we'll be talking about the testing, the do's and the don'ts of testing. In other words, what are the kind of pitfalls that you have to look out for, or what are just some of the basic requirements that you'll need to know. And then we'll focus a lot of our time on the new natural treatment protocol in terms of diet and supplements. So some of you who've listened to previous webinars have heard me say this before, that basically SIBO is, or small intestine bacterial overgrowth, from here on known as SIBO, is a condition where you have an overgrowth of bacteria that are normally found in the large intestine. And just to give you an idea, the small intestine, from the duodenum all the way to the ileocecal valve, is supposed to be fairly limited in terms of bacterial growth. So you'll have the duodenum that is virtually sterile because of hydrochloric acid production and pancreatic bicarbonate production. And then as you move down to the jejunum, you'll start to see a little bit of bacterial growth. And then as we move through the ileum and towards the ileocecal valve, we go from 0 to all the way 10,000 units, or colony-forming units per milliliter. So you can imagine that it's not a whole lot of bacteria as compared to the colon, which is something to the order of 100 billion organisms per milliliter. Anything over 10,000 colony-forming units, therefore, is considered bacterial overgrowth in the small intestine. So normally, we do have some normal antibacterial control that is basically hydrochloric acid. So anything that we ingest through our with our food, because our food is basically loaded with bacteria, is supposed to be killed by the incredible acidity of the stomach, which has been likened to car battery acid. So once hydrochloric acid is produced, that also stimulates the release of pancreatic enzymes as well as bile through various different mechanisms. So these are the normal antibacterial mechanisms that we have. Now, normally what happens is that every 90 minutes between meals, we're supposed to have this cleansing wave that basically sweeps through the small intestine that ensures that no residual bacteria are left in the small intestine. Because the small intestine is so loaded and covered with absorptive surface that a bacterial overgrowth in this area would really compromise absorption. So that's sort of the housekeeping of your body that sweeps the remaining food and particles towards the cecum. It's only about 40 centimeters long, this migrating motor complex. And what it does is it moves the chyme or the broken down food along at about 6 to 12 centimeters a minute. In the migrating motor complex, I usually explain it in a way that, you know, that kind of grumbling or growling that you experience when you're really hungry, that's actually the migrating motor complex. And this, sometimes you can even see a visual sort of movement in the epigastrium right below your sternum. The migrating motor complex is generated by the enteric nervous system and also by a little peptide called motilin. And motilin is secreted by the in the small intestine, and it basically stimulates this cleansing wave. And the major part of our new treatment protocol focuses on correcting a paralyzed migrating motor complex, because what we found is that in almost all cases, I would say, of SIBO, what we find is that that migrating motor complex is impaired. And so therefore, after we've treated a patient for our, you know, typical 6 to 12 weeks, and they're doing great, but those that don't have a migrating motor complex that has been repaired often suffer relapse. So that is now a major focus of our treatment plan that we'll get into a little bit later on. So this bacterial overgrowth that is allowed to ferment in the small intestine, let's say for various reasons the motor complex has been impaired. Now bacteria that are allowed to stay in the small intestine basically get a smorgasbord of food thrown their way, because right below the stomach, it's basically a free-for-all for these bacteria, so they can grow fairly quickly. And anything starchy and certain water-soluble fibers are very, very fermentable by these bacteria. This fermentation by the bacteria produces hydrogen and methane, and as well as hydrogen sulfide gas. Now, we are only going to be talking about hydrogen and methane because these are the current gases that we can measure with breath testing, but hydrogen sulfide gas is also present, and we'll talk about sort of roundabout ways of how to assess whether or not this patient may actually have an issue with hydrogen sulfide. The gases that are produced by this bacterial fermentation cause pretty much all of the symptoms of SIBO, or a large percentage of the symptoms, and that is bloating directly after meals. I'd say that's probably the most common symptom. And the gas also causes the damage to the microvilli. which again is your absorptive surface in the small intestine. So what we see with long-term SIBO is basically malabsorption, and so anything that you can associate with malabsorptive symptoms, such as low ferritin and obviously cramping in the legs because of magnesium malabsorption and zinc deficiency, and all these things that can be compromised because of a gas production that causes the damage and absorptive surface. Another important consequence of SIBO is the deconjugation of bile acids. And what happens is bile is released from the bile duct in response to cholecystokinin, but also fatty acids in the food, and it causes the bile acids to actually break up and not be functional anymore. And so the oils and fatty acids can no longer be properly emulsified. And so what we also see later on in a little bit more long-term SIBO is fatty acids malabsorption, so omega-3 fatty acid deficiency, vitamin D deficiency, vitamin E deficiency. So all these fat-soluble vitamins can also be very, very compromised in terms of absorption. SIBO is now considered by many experts to be actually the main cause of irritable bowel syndrome. And what we've, back in the 80s and 90s, we thought that IBS was solely caused by stress. And what we now know is stress definitely worsens existing symptoms. But when people are, when their stress has improved and their symptoms still remain, that's sometimes a big clue that SIBO might actually be present for these patients. In this study, and this is actually from Dr. Pimentel, he looked at patients that came into his gastroenterology clinic, and 84% of these IBS patients that he's tested with a lactulose breath test alone tested positive and improved with treatment. That's actually really key, is that not only did they exhibit bacterial overgrowth, but absolutely improved with the use of antibiotics, as is the case of Dr. Pimentel. The symptoms of SIBO are, again, bloating after meals. And what I find, or what I usually ask patients is, how quickly after meals do you actually experience your symptoms? Is it 10 minutes, 5 minutes? Is it 2 hours? And so when somebody says, I get bloating with water, I get bloating anytime I eat anything, that's a huge clue. Because if it's something like, meat just sits in my stomach and I get really, I get a lot of wind with a lot of meat, I think more hydrochloric acid deficiency. But this to me is almost always present, this bloating after meals. Flatulence or wind is very common. Diarrhea or constipation or alternating, so classic IBS type picture, as well as abdominal pain, and that can be because of distension or cramping, as well as nausea or this epigastric discomfort. I've actually seen quite a few patients come in with that being a predominant symptom, this pain or discomfort right under the sternum or the xiphoid process. And it's almost like, that's also where energetically there's a lot of stuff happening, and there's, if you're not breathing correctly, for example, the diaphragm can certainly be quite spasmodic, or can be sort of stiff when people are just chest breathers. So really check that out for people. But I have found a lot of my patients actually have some issues with this nausea and discomfort right below the xiphoid. Reflux, don't discredit people for or ruling out people for having SIBO just because they have reflux. It's actually also can be quite common, and that makes sense because when you have fermentation and gas production, and some of that gas will actually push the acid from the stomach up into the esophagus. Joint pain and skin rashes are common, as they're pretty common with most digestive disorders. I think we can all agree, but especially with SIBO we see this as well. Associated conditions, rosacea, I'd say, and restless leg top of the list. I absolutely think rosacea has a huge root with SIBO, and the Delphi panel that I was a member of also had Dr. Larry Weinstock, who's another gastroenterologist, and he did a lot of studies around rosacea and clearly demonstrated resolution of rosacea when it was treated as SIBO. So that was pretty exciting. Restless leg syndrome, we know that can also be because of low iron and magnesium and those types of things, but there were actual specific studies with restless leg syndrome and SIBO, and we know that's just a little bit of a heads up when somebody lists that on their symptom list. Obesity, I think obesity is pretty much associated with a lot of different conditions, but as well as fibromyalgia. Fibromyalgia is very much linked to SIBO, especially with very high levels of hydrogen, and we'll look at those lab results a bit later on. NASH is non-alcoholic steatohepatosis, a condition where part of the liver is turned to fat, and that's also very much associated with SIBO. Hypothyroidism, inflammatory bowel disease, as well as celiac disease, anything in terms of inflammation can also be linked to SIBO. I think with chronic prostatitis and interstitial cystitis, what we're seeing is a mucosal inflammation that is systemic, and I often see that with my interstitial cystitis patients, is that they clearly have a connection in the digestive tract, and anything from mouth to anus as well as vagina and bladder is mucosa and can be irritated and inflamed just from if one area is inflamed, it's not uncommon to have other areas, just like mouth ulcers are very common in people with celiac disease. So we often see that in SIBO patients. Diabetes, I think one reason is because of the issue with gastroparesis, where we have very, very slowed gastric emptying, as well, of course, very compromised digestion and diet in general. Scleroderma and other autoimmune diseases can also present with SIBO, and that has to do with the involvement of the nervous system, and we'll discuss that when we look at vinculin and autoimmunity and IDS, which is a very, very hot off the press developing field. Diverticulitis, we can see that in the small and the large intestine. Again, this is more long-standing compromised digestion in general, but anything that causes stagnation in the digestive tract can certainly contribute to the development of SIBO. The most important cause of SIBO, and I'll just pause here and say that it's one of the sort of, again, light bulb moments that I had when I was at the recent SIBO symposium. For me, it's so easy to treat SIBO because I treat it all the time, but to not ever forget that it's caused by something. SIBO itself theoretically is not a diagnosis. It is caused by something, just like Candida is caused by something. It's caused by either post-antibiotic use or high consumption of sugar. The causes of SIBO need to be addressed for there to be long-term resolution of this condition. And I think by far what we see is a post-infectious picture. And what that means is somebody had a case of gastroenteritis or food poisoning and then sort of either never recovered, and what that means is that their migrating motor complex, that cleansing wave, was affected, or there was a little bit of a lapse in between the case of food poisoning and the development of SIBO. And we will talk about that in a few slides when we talk about autoimmunity. Diabetic enteropathy, as I've mentioned, is basically a condition where there's going to be slow reflexes and slow enteric nervous system involvement because of basically diabetes, the process of diabetes. And again, it will slow down normal digestive function and can certainly lead to SIBO. Blind loops, which can happen after gastric bypass, so certainly check with gastric bypass patients. I mean, they're going to have a host of issues anyways in terms of potentially poor absorption and so forth. Also pseudo-obstruction, which is a mechanical obstruction without evidence of any kind of anatomical obstruction, so that'd be clear on a scan. But what we see here is potentially areas of severe restriction because of sympathetic overdrive, so your nervous system and stress to the digestive tract can cause little areas of pseudo-obstruction. And I think one of the most important that I look at, I mean, we don't see blind loops all the time, but we do see adhesions a lot, because every one of us has patients that has had abdominal surgery, whether that's appendix removed or endometriosis, having cesarean sections, also removal of the gallbladder, even those minor, I don't think as naturopaths we would ever consider that as minor, but even what conventional medicine would say is a minor intervention can lead to abdominal adhesions. And then if you think about an adhesion which is just fibrous tissue and scar tissue that can pull the small intestine to the side, so you'll create sort of like a kink in the garden hose. And so above stream from the garden hose, you can actually have stagnation and just pooling of digestive fluids, which lends itself to bacterial overgrowth. And then I also listed IBS because that's more linked to the post-infectious. So when somebody comes in with irritable bowel syndrome, because 84% of people are likely to have SIBO, you do want to consider SIBO as a diagnosis, but also check to see if they've had any sort of previous infections, because that could be the cause of SIBO, as we'll see in a moment. Other causes include medications, and this is something to be really aware of, whether they're on a proton pump inhibitor, or they've taken codeine or morphine, or other sort of illicit drugs, marijuana, those types of things, can certainly interfere with the migrating motor complex. And just sort of as an aside, the migrating motor complex, which just sweeps through the small intestine, is not really the peristaltic motion of the large intestine. So you can have people with impaired migrating motor complex and still have diarrhea, for example. So it's not, that was just as an aside in case I didn't mention it before. But really check with people's medications. I see a lot of people with chronic pain. People are on codeine or morphine. And certainly more commonly we see these proton pump inhibitors, which I'm always discussing with people as for ways how to get off of them, because they really do impair digestion quite severely. Unless, of course, somebody has Barrett's esophagus or something very sinister, you do want to consider removing them from proton pump inhibitors. Calcium channel blockers is more of a theoretic possible interference and cause of SIBO, but medications or hypertensive medications such as Norvasc, so just check for that. Stress, of course, we always check for that, but stress in particular has two effects on the digestive tract which could potentially lead to the development of SIBO. And one is the hydrochloric acid output, so less acid, less bacterial killing, and less stimulation to the small intestine to have a cleansing wave. Also, the motility of the small intestine is affected very much so by stress. And we know that the enteric nervous system is involved in sympathetic or fight or flight actions, as well as rest and digest, or the parasympathetic. So part of my protocol or screening that I do is I always gauge stress levels. I'm sure all of us on this call do that, but it's important also to consider that as a cause of SIBO. So when somebody has adhesions and a lot of stress, which is a lot of people in my clinic, it's not unlikely and not too far-fetched to think that they have this digestive disorder. Also, just simple overconsumption of carbohydrates, especially simple carbohydrates like sugars and lollies and sweets and so forth, certainly can lead to overgrowth of bacteria. But again, you must have something else in place that either paralyzes the migrating motor complex or causes this stagnation in the small intestine because of adhesions or so forth. Initial colonization because of cesarean birth, that's more of a theoretical potential for the cause of SIBO. So let's have a look at SIBO as an autoimmune disease. So basically, common bacteria like Campylobacter, Salmonella, and so forth, but particularly Campylobacter, which is quite common, can cause food poisoning, and these bacteria produce a toxin called cytolethal distending toxin B, or CDTB, and parts of this particular toxin are similar to human vinculin. And vinculin is a cell membrane cytoskeletal protein that is important for nerves to stretch out and to connect to each other in the enteric nervous system. So without vinculin, nerves cannot really communicate and talk to each other. So what happens is that it is now believed, and this is really spearheaded by Dr. Mark Pimentel, who's really pioneered this research, has said that most IBS, they're thinking now, is because of this post-infectious gastroenteritis and this issue with antivinculin antibodies. So in an effort to clear this toxin, and due to the similarity between this toxin and vinculin, the body mistakenly produces antivinculin antibodies. So really a classic autoimmune response, which leads to damage to the enteric nervous system. And this then causes the damage to the migrating motor complex. And so what we see sometimes is the gap between the resolution of the gastroenteritis. So somebody had food poisoning, then they improve, and then a month or 2 months later they develop SIBO symptoms. That's actually the gap time in which autoimmunity can certainly be developed. So this is the IBS hypothesis according to Pimentel. So if you start at the top, the general population here, some will have bacterial gastroenteritis, and a subset of those people will develop antivinculin antibodies. And if those antibodies are quite high, that leads to the development of IBS. And if those antibodies are low, those people will not develop IBS. So there are antivinculin antibody as a test is not quite ready for distribution to other labs. So it's an in-house test that they're doing now, but it's looking very, very promising. So mainly his whole take-home message is that most people, if not all people that have IBS, have a history of infection, and then couple that with stress and everything else, these people certainly have an issue with IBS. There is not enough data yet to utilize antivinculin antibodies as a diagnostic test, and Dr. Pimentel doesn't really believe that it'll replace the breath test as a preferred diagnostic test for SIBO. So we are still using breath tests as a preferred method to diagnose. So let's have a look at breath testing. And what we now use as nomenclature is that SIBO-D is diarrhea dominant, just like we used to do with IBS-D was diarrhea dominant, and SIBO-C is more constipation dominant. And what we see is that in SIBO-D, the diarrhea dominant type of SIBO, the 4 organisms that are very predominant are E. coli, Klebsiella, Proteus, and Aeromonas. These produce hydrogen gas. And just sort of as an aside, for those of you that do stool testing really is not a diagnostic test for SIBO at all. It really cannot be assessed having all those bacteria come through the large intestine and be collected in the stool sample. That's not accurate at all for the diagnosis of SIBO. So that's just as an aside, because I still do a lot of stool testing and I see these 4 organisms commonly on a stool test, but you can't deduce just because they're there that they'll also be causing SIBO. SIBO constipative dominant SIBO is caused by something called Methanobrevibacter smithii, or a methanogen which produces methane gas. And again, hydrogen sulfide gas cannot be assessed with breath testing at this stage. There is a urine test that won't give us a quantitative result, more just a qualitative result. But I am not completely convinced yet that that's diagnostic for that yet. But Quintron is actually working on having breath testing available fairly soon. So that should be coming in the future. So hydrogen and methane gas are the direct result of this bacterial fermentation in the small intestine. They're absorbed into the enteric circulatory system and then transported into the lungs. So basically bacteria eat some starch and sugar and food, and they produce the hydrogen or methane gas, and that then goes into circulation and you breathe it out. And these gases can be captured with the testing equipment. Hydrogen is the predominant gas assessed in the hydrogen breath test. But what's really important to know, and we will look at the test result a little bit later on, is that hydrogen is actually used by the methanobacters to make methane. So if you don't have any hydrogen producing bacteria, you don't actually make a whole lot of methane. But those that have methanogens in their digestive tract almost always have a lot of hydrogen producers as well, because that is directly feeding the methanogens. Also, hydrogen sulfide uses hydrogen. You can see that it uses two basically molecules of hydrogen to make one molecule of hydrogen sulfide, and methane actually uses 4 hydrogens to make one molecule of methane. Methanogens are a whole new, basically a breed onto themselves. So we have, when we look at the kingdoms of life, we look at the eukaryotes, which are plants and animals. We look at the bacteria, which is Salmonella and E. coli and Klebsiella. And then we look at the archaea, which are the methanogens. And methanogens are absolutely fascinating little creatures. They live in extreme environments. And they're not bacteria. They have different nucleic acids. So what we see in sub-Saharan Africa is that they actually have a lot of methanogens, because methanogens are very good in extracting calories from food. So it's very beneficial to nomadic people to be having methanogens, because it can extract calories from things that like tubers and fibers and things like that. So it's beneficial in some cases. But when you have an extreme overgrowth that produces a lot of methane, you run into the problems that we see with SIBO. But what's interesting is that the microbiome can't really sequence these organisms, because the microbiome project is based on regular DNA sequencing. So we'll have to wait a little while before we find out more about the Methanobrevibacter smithii, but these are the predominant source of methane in humans. In studies, what we see is that when methane gas is infused into the unfortunate animal or laboratory animal, it causes constipation in over 70% of the animals. So we know it's an instantaneous effect. And unlike hydrogen, the levels of methane on a breath test can actually predict the severity of symptoms. So in other words, the higher the level of methane, we can imagine, or we can predict, that it's actually a much higher or worse case of constipation. I mean, like most of you, I've got patients that have been constipated for many, many, many years, where they can't actually have a bowel movement but once a week, or sometimes even worse than that. So it's a real issue, and to be honest, the SIBO-C cases, or any constipation that's that long-standing, is really tough to treat, even with SIBO. I do have much better results now with those cases, now that I do treat SIBO, but it is still, of the two, it's still a lot harder to treat methane dominant. So a rise of 3 parts per million is diagnostic of SIBO. So when we look at a test result, this is what you'll get when you order a test through SIBOTest, and we'll talk about how to do that. It's very, very simple. You just have your patient order it online, and we will forward the test result to you. So this is something, this is a result that you would receive. And what we look at is, and again, we'll go through the testing in detail a little bit later, so but this is just a little preview, is that here are all the samples. So there are 10 samples through a 3-hour test. Here's hydrogen, and here is methane. So if we think about a rise of 3 is actually diagnostic for SIBO, we go from 24, starting the control. So here's the control, and we started with 24, and within 40 minutes it's jumped up to 38. And then it kind of jumps back and forth a little, and then it goes to 58. And then it goes to 83. So this is a severely constipated patient. This is more of a graphical presentation. This is going to be the second page once you receive your test results. So we really see the ups and downs. It's quite common to see that in a test result. But anything within 90 minutes of a rise is fairly positive within the parameters. So a rise of 3 parts per million is certainly positive for this patient. So the SIBOTest lab that I founded uses the Quintron hydrogen breath tracker machine, the same as what is used at Dr. Pimentel's research clinic. Quintron has been used for many, many years for the use of breath testing, and is used by many other labs, but it is considered the gold standard for breath testing. We only use vacuum tubes for home collection kits to ensure proper collection, and that was actually my main reason to actually develop SIBOTest lab, is because I was so frustrated with the faulty collection kits, as well as the the results that I was getting from other labs. It just constantly was consulting with Dr. Seebecker overseas, and it was then I was just getting too frustrated, so I decided to actually develop my own lab test, which is great. So we're the only lab to also offer Lactulose only SIBOTest kits, and we'll explain that in just a minute because that's an important differentiation. The SIBOTest kits test for hydrogen, methane, and carbon dioxide. And the reason why we test for carbon dioxide is because we make sure that that sample was collected properly. So carbon dioxide has to be in a particular concentration, and if that has not been reached, then we know that that sample was not collected properly, and we discard that particular sample. So other labs use lactulose only as a measurement of transit time. And so that means that they discard the results of the lactulose test and say, no, that's your hydrogen producer, and so that just means that we can measure, or we can actually test you if glucose is positive to diagnose SIBO. So glucose, as many of you may have heard in previous webinars, is absorbed very, very quickly in the first part of the intestine, sometimes even in the duodenum. So before it even leaves the duodenum, it's already absorbed. So it really is not a very good test sugar. I still use it in some cases, as you'll see, but it's no longer, I don't do glucose and lactulose anymore on every one of my patients. So lactulose is used by Dr. Pimentel exclusively. He's done over 19,000 breath tests and uses only lactulose. So what his argument is, that lactulose is more than a measure of transit time, is that in the test kits, 10 grams of lactulose is given to the patient, regardless of body weight. 10 grams is given in water. And we know from motility studies done in gastroenterology that 5% of that lactulose arrives in the cecum after 1 hour. So it takes about an hour of 5% of that lactulose to go all the way through the small intestine to the first part of the large intestine. And therefore, 95% of it is still in the small intestine. Once it arrives in the cecum, it takes the colonic bacteria up to another hour to ferment that arriving lactulose, which means that it takes a total of 2 hours for the colonic fermentation to affect the breath test. And our tests mainly look at the first 2 hours. That's the most important time. So if we have a rise in hydrogen or methane, we know it has to be the small intestine. Sometimes you'll have a patient that has extremely rapid transit time, and you do have to take that into consideration, that they were pretty much explosive diarrhea, but it happens very, very rarely. I'd say 1 out of every 50 or 60 people will have some sort of really sort of colonic effect, but that that is important in terms of whether or not you can use that as an accurate test then. So here's another test result that looks at lactulose, and what we're looking at is again, you have, here's your control. This was done before any lactulose was consumed. So we have sample 1, and this particular patient started with a hydrogen level of 1 part per million. After about 40 minutes, she jumped up to 29. And the diagnosis of SIBO means that a rise of lactulose within the first 90 minutes of 20 parts per million. So this patient definitely is positive. She goes up all the way to 47, which is very, very diagnostic for SIBO. And then this is quite common, where we see then a reduction and then sort of jumping around again. At 160 minutes to 180 minutes, it's really where we are seeing, again, at 120 minutes, we start seeing the arrival of the lactulose and the fermentation of the lactulose in the colon. So we do expect anything after 120 minutes, especially if it's a rise that's every subsequent level is a bit higher than before, we can assume that there is some colonic involvement at that point. Here's the graph. So we see a huge rise of hydrogen of 20 points and then continuing to climb and then going back down again. So I'm assuming right here is where we start to see the cecum and then the large intestine involvement, which is then not SIBO. The glucose breath test, again, I still use glucose testing, although not with every patient, because of this rapid absorption in the first part of the small intestine. And so very often, if you only use glucose as your diagnostic test, you can very easily miss the SIBO that's much closer to the ileocecal valve. And so think about that think about using glucose when somebody has classic SIBO symptoms but has a negative lactulose breath test. And this does happen. This is an example of a patient of mine, quite recent actually, a couple of months ago, that had, for all intents and purposes, a very negative breath test for lactulose. So where we see a control of 2, really nothing is happening for the first 120 minutes, then we see a rise of about 16 because we look at 2. We look at 2 and, oh, hang on, what happened? I've got to go back up. So we see a rise of 16 from 2 to 18, always the lowest preceding one. And then we go up to 20, and then 19 again, going back down a little, and then back up to 27. So this is not a rise of 20 parts per million, and so therefore not diagnostic for SIBO. But then we also, I was very suspicious of this patient because she had very classic symptoms, and she had a lot of diaphragm spasm and a lot of pain under her rib cage, and it felt like a rubber band around her thorax, and she did have a lot of bloating after meals, and I said, this has got to be involved. So I ran a glucose test, and what we see with glucose, if you can imagine, that any rise in glucose is really positive because of this rapid absorption. There shouldn't be any rising of any gases, and we saw a rise of over 30 points within 40 minutes, going up to 69, 78. This patient was miserable with this test. So very positive for SIBO here. One common question I get from practitioners is why not just treat and just see what happens? And why, I mean, that's a good question, because sometimes we do that with candida. It's just like, let's go on an anti-candida protocol. If you improve, that means that you actually had candida. But there's a few points here that I want to point out. And one is that SIBO is a very specific condition which requires very specific treatment. That means many products that we very routinely prescribe for digestive issues or disorders are actually contraindicated. That means you can make a condition worse. You can worsen SIBO by giving, for example, slippery elm or arabinogalactans or the wrong probiotics. So that's really important to know. Also, based on gas levels, the practitioner will know, or you will know, how many cycles of antimicrobials a patient will need. If also, this is, I think, maybe the most important, is that if you stop treatment too soon, then relapse is very common. It's not like where we, again, just as an example, treat for candida, that all of a sudden secretory IgA kicks in and they start to really have their own inner resilience and immune function, treating the rest of the remaining candida. This is actually where you need to reset the migrating motor complex, and you need to know whether or not the bacterial presence is gone. So important considerations before testing is 1 month prior to testing, the patient must not have had a colonoscopy, a barium study, or antibiotics. Obviously, we don't want any killing off even just a few bacteria that we could otherwise capture via breath test. A week before testing, you want to stop all herbal antimicrobials as well as probiotics, including yogurt and Yakult, and acid blocking medication. So this is including natural soothing digestive aids and things like that. But the day before the test, absolutely no laxatives, and digestive support supplements should also be discontinued, just to make sure that we really capture every gas molecule that we can. The prep diet is a simple diet that you will that will be included in the test kit that's sent out to the patient, and they start 24 hours before testing if they're not constipated. But they want to start 2 days before testing if they are constipated. So just to make sure that we get a really, really good baseline for those constipated patients. The allowed foods during this time is meat, fish, chicken, eggs, although any kind of really heavy protein consumption can slow down transit time, so we want to keep those portions fairly small. Also, white basmati or jasmine rice, no brown fibrous rice, and this is a ½ cup per serve. And then salt, pepper, olive, or coconut oil. No fruit, no vegetables. And the night before the test, they want to be fasting for 12 hours. So that's pretty simple. They go to bed at, or they stop eating at 7 p.m. the night before, and then they can start testing at 7 o'clock in the morning. If you ordered 2 test kits for your patient, let's say a lactulose and a fructose, to make sure, because you wanted to see if they were also fructose intolerant, they do want to complete the first kit, then go back on the prep diet and do the second kit the following morning. So the SIBO breath test is basically after the overnight fast, the patient collects a baseline breath sample. So this is before they consume the 10 grams of lactulose or glucose. And then samples are collected every 20 minutes for 3 hours. And that ensures really checking how quickly that sugar is moving through the the small intestine. Hydrogen, a rise of, again, as I've mentioned before, 20 parts per million over the lowest reading by 100 minutes is positive for SIBO. And methane, a rise of 3 parts per million over lowest reading by 100 minutes is positive for SIBO. A later rise in those gases may still be SIBO, and this is what you'll see on the test result. we'll say either inconclusive. It really depends on what the symptoms are that your patient has. So for example, if you had a patient that's been constipated for many, many years and they can't have a proper bowel movement and nothing happened, they consumed the lactulose and they didn't have a bowel movement for, let's say, 3-4 days afterwards, and they have a really late rise, I would still consider that to be within the realm of SIBO, because their transit is just so darn slow that it just took a long time for that to reach the cecum. Here is an example again of another patient that had a positive lactulose. We see 0 at the beginning, so this patient really prepped very well. I also want to just draw your attention to the carbon dioxide and the explanation down here. We will alert you if any sample was non-readable or had to be discarded, so that's where you'll, in this note box down here, will alert you to any of these incorrect sampling methods. But yep, so we have somebody here who went from 0 to 27 in 100 minutes, so that's a rise of 27, which fits the criteria for the diagnosis of SIBO. Here you see the rise in the large intestine, so a very nice and neat diagnosis here. Again, the graph, you can see a little bit later rise, but still very diagnostic. Sometimes we see that the results are actually flatlining, which means that both hydrogen and methane levels remain 0 and 1 all the way through the test. This is abnormal, as we do expect to see that late rise as the sugar arrives in the large intestine. So firstly, you want to check if carbon dioxide levels are all correct, and that's any reading above 1.5. Again, it'll be very clearly written on the test result. But what we see is, and what was really made very clear at this SIBO symposium from Dr. Pimentel, is that very often that's actually or signifies the presence of hydrogen sulfide. And as I've mentioned, hydrogen sulfide is made by 2 molecules of hydrogen, so it's really required for the production by other bacteria. So, and sometimes people that have hydrogen sulfide dominant SIBO will have very rotten egg kind of breaths, and will also have sometimes a bit more neurological involvement in terms of numbness and tingling and so forth. But we're still waiting for proper testing to be able to assess hydrogen sulfide correctly. So this is an example of somebody who had zeros all the way across, and also had fairly non-rising levels of methane all the way across. So this is somebody that I suspected had hydrogen sulfide. Okay, finally we've arrived at the natural treatment protocol. What do we actually do about this? The key points really is that you want to be on antimicrobials, or you want to have your patient be on antimicrobials for 6 to 12 weeks. And before it was always just 6 weeks. Now we're saying depending on gas levels, so if gas levels are above 35 to 45 parts per million, whether that's methane or hydrogen, you can expect an average decrease from every round of antimicrobials to be about 25 to 35 parts per million per cycle. So what that means is, let's say somebody had a methane level of 75, each 6-week course of the antimicrobial will bring it down probably down to 50. And where we want it is to be like less than 10, and we don't want any rise anymore. So that's really what you're looking out for, but 50 is still way too high. Another key point is that constipation cases, as I've mentioned, are much harder to treat. You also want to retest to assess results. I do this all the time, and then I can tell whether or not this patient needs to be on another round of antimicrobials. If they're above 50, for sure I won't retest until I've done at least 2 cycles of antimicrobials. But oftentimes, if patients say, my symptoms are gone, can I get off this diet now? You can always say, let's ask your body, let's just see what's still happening, and retest to see if that's really resolved, because then all you need to do is focus on the diet and the prokinetics. Now, prokinetics are nutrients and herbs which stimulate the migrating motor complex, and this is really a work in progress. We've come across that when I was on the Delphi panel, we had several other naturopathic physicians who have done this for a long time, but we're all on the cutting edge. To some extent, you're on the cutting edge because you may know something that's really worked for your patient, and if that's the case, then I really do need to know what's worked. But I will give you what's worked for me, and there are some herbs that we're looking at that are pretty exciting, so that's good. The diet part is you need to realize that these people are going to be on a restricted diet for 3 to 12 months, depending on how long this condition has been with them. There's absolutely not one single diet that fits every SIBO case, so you might have to adjust. So sometimes people, for example, that lose a heap of weight because you've reduced or eliminated all the grains. That happens quite a lot in those that are especially have a huge sympathetic, have a lot of stress in their life. They do tend to lose a little bit more weight. So you might have to introduce a bit of rice sooner than later. The diet we'll talk about a little later, that's also changed from the previous recommendations. So let's have a look at some of the problematic ingredients in supplements that we see. They actually are contraindicated during the treatment of SIBO, and that's mainly due to fermentable starches and sugars and fibers. Prebiotics, so not every probiotic that you give your patient is useful in SIBO. You must avoid all those that contain the fructooligosaccharides, the galacto-oligosaccharides, and the maltol oligosaccharides. Those are just all the prebiotics that feed good bacteria, as well as inulin and chicory, and also arabinogalactan. And I was a bit bummed out about that because I really like arabinogalactan as a glycocalyx repair for the small intestine and for the large intestine. Also a nice little fiber, but we can't really use it during the treatment of SIBO. Gums and starches, so acacia gum, Arabic, beta-glucan, guar gum, locust bean, so carob is contraindicated, mastic gum, which is often used for peptic ulcers, etc., xanthan gum, any of the starches, corn, brown rice, maltodextrin, this is often found in certain supplements, but above a certain amount. So sometimes you have to just gauge it to see if they're going to be reactive to it. And my rule typically is that you want to get them to a place where they're just not reactive, and then you can have a little bit more leeway with certain foods to see if they're going to be reacting or getting some of their symptoms back. Also soluble fibers, such as flaxseed, psyllium, pectin, and that's often found in jams and yogurts, and that's not going to be allowed anyways. But also, just as a side note, is that cellulose and hemicellulose and other celluloses are actually insoluble fibers, and these may cause irritation to the inflamed intestines, but are only partially fermented. So they're less likely to feed bacteria and can therefore be more tolerated. That's why vegetables are allowed on the SIBO diet, even though they're quite fibrous. Sugar alcohol, anything that ends in OL is a sugar alcohol. That's erythritol, maltitol, mannitol, sorbitol, and xylitol. So some of the supplements that different companies are using actually use xylitol, so you have to just be aware of that. The only sweetener that's allowed is stevia. Seaweeds and sweeteners, well, actually I should say there are other sugars that are allowed in very tiny amounts, and we'll get into that in the diet. But alginates and carrageenan actually is found in a lot of things like unsweetened almond milk, or anything that is those long life milk alternatives often have carrageenan as a stabilizer. Otherwise, all the almond solids would just be on the bottom. But I found that sometimes when I recommend the SIBO diet to people, they really need something, and they have egg allergies. They just really need a protein shake for breakfast. So either I have them make an almond milk themselves, or I recommend the Sanatorium almond milk. It does have carrageenan in it, but again, in probably very small amounts, and perhaps if you remove everything else, you can sort of compromise a little bit to get somebody in a very doable protocol. Also agave, lactose, any kind of sugar or sucrose, although Pimentel allows sucrose because it's very easily absorbed in the small part of the intestine. But as naturopaths, you know, we sort of have, we don't like to recommend sugar and sucrose, but also because often there are co-infections with candida and things like that. So until people are really improved, I try to keep this all to an absolute minimum. Just as a note, dextrose is glucose, and this is okay for some, whereas maltodextrin is actually starch. So glucose, because it's rapid absorption in the small intestine, might be okay for some, but again, you're going to have to first start to get them to a place where they're not reactive. So the products that I'm going to talk about now are based on my own experience treating SIBO. I have no affiliation with any of these companies, and it's not meant to discriminate against a company or product by omission. It's a work in progress. I use a lot of overseas companies like Thorne and Ayush and Pure Encapsulations that you can get from FX Med, the distributor in New Zealand, and I've written the contact details there. And this is, you know, this is one of those moments that comes very rarely, but I'm just so, it's so wonderful for me right now to be able to tell you the products that I really find are working for me, and I'm not bound by the guidelines of different companies and what I can say. So this is a wonderful moment right now. I also use NRG, and I use Biomedica, which is through NRG, and it's actually a keystone or cornerstone product is Alimax, and we'll talk about that in just a minute, and also Orthoplex NAC. So herbal antimicrobials. Garlic is for sure the star, especially if methane is the predominant gas in your patient. You can't use whole garlic. It's actually contraindicated, and it's not allowed in phase 1 because of high fructan content. It's high FODMAP. So it means it contains a fiber that's very fermentable. So allicin, which is in this product Alimax, it contains only allicin, which removes all the fructans. And what you want to do is you want to dose the allicin from 180 to 500 milligrams 2 to 3 times daily. My typical dose of allicin is 3 capsules twice a day. Again, this is from Biomedica. The other thing that I want to mention here is that it has a bit of golden seal. So it's a really good combination of both allicin and golden seal. And golden seal, as we'll see, is a berberine containing herb and listed in this list here as hydrastis. And berberine is a wonderful herb for especially hydrogen producers. And these are the different plants that contain berberine, coptis and philodendron, berberis, aquifolium, which I love. It's a wonderful herb. And Berberis vulgaris, as well as hydrastis, which is golden seal. Golden seal, of course, is very, very expensive. So if your patient can afford it, they can use hydrastis, but it's difficult to find pure powder of golden seal. So I usually stick with something called Berber caps, which I'll talk about in just a minute. But berberine is active against a wide spectrum of bacteria, and again, typically useful with hydrogen-dominant SIBO. And sometimes you need very large doses, up to 5,000 milligrams daily in very resistant cases. And just one word of caution is that high doses of golden seal, not other berberine herbs, inhibits a particular CYP enzyme in phase 1 liver detoxification. And those that are also on SSRIs or selective serotonin reuptake inhibitors, that high dose of golden seal may actually deactivate this enzyme, meaning that they're going to have a lot more of that SSRI hanging around. So just be aware of that. The product that I used to use Thorne Berber caps, but now I'm switching over to the berberine 500, which is basically just a much higher dose, and so that means less capsules. But if you can imagine up to 5 grams daily, that means up to 10 of these dailies. But it really depends. Your first course of antimicrobials, I usually keep it at 3 caps twice a day, and then kind of go from there depending on how severe the symptoms still are. Metagenics, Bactrex, I get sort of mixed results, but I wanted to put that in there, especially if you have concomitant candida infection. It's a pretty good one. That one uses the philodendron as a berberine-containing herb. I also use neem, which is an Indian herb, as an adjunct. I don't use it as a standalone antibacterial, but itself is pretty good. And it's Dr. Stephen Sandberg-Lewis, who runs the SIBO Center in Portland, Oregon. It's associated with the NCNM, or the National College of Natural Medicine, Naturopathic Medicine in Portland, and its brand new SIBO Center often uses the neem as an adjunct to potentize other herbs, and we like to do that as naturopaths, I think. But I have found sometimes you can actually reduce the dose of other more expensive herbs if you use neem, but initially you do want to observe the recommended dosages. So Ayush Neem Plus is the product that I use. It does have other herbs in there, but the neem is obviously the carrying herb. You want to use that alongside either the Alimax or your berberine-containing herb. Other antimicrobials that deserve some consideration is oregano, as well as colloidal silver and olive leaf. I have not used them, so I cannot say. I mean, I use the oregano in the Bactrex, but not as a standalone product. So this is, again, areas that require further investigation. Natural prokinetics is just such a fascinating area. These are motility agents that actually stimulate or endeavor to stimulate the migrating motor complex. And they are used throughout the entire treatment. And that's phase 1, phase 2, and beyond. So perhaps even for years, depending on how paralyzed that migrating motor complex is. And you might have to go through a few, and I have to do that sometimes. You might have to rotate to find which works best for the individual patient. I've bolded my favorites. I use bitter herbs, and I'll give you my formula in a minute, as well as 5-HTP. 5-HTP is actually a serotonin precursor, and serotonin is one of the predominant neurotransmitters that stimulates motility in the digestive tract, as well as an Indian herb, triphala. So those are my top 3. And then melatonin, as we know, we can no longer give that to patients. So I just list that here as a potential for those that can still prescribe it. And that would be at bedtime. It's a sort of a theoretical for the migrating motor complex, but for the sake of really reducing the pill counts for your patient, you do want to see if they're already on that, but it has to be a dose of 3 to 5 milligrams or so. There's some exciting recent research that Bifidus infantis is actually a natural prokinetic, and I cannot find Bifidus infantis by itself or as a standalone. So I use Ultraflora Restore dairy-free by Methanogens. And also, this is something I'm investigating now. This is a Chinese herb called immature bitter orange. So this is not the bitter orange that you use for tonsillitis and stuff, but this is a specific herb that I'm still trying to source and see how that works. The products that I use, probably the main one would be a product called Motil Pro. This is by Pure Encapsulation, and again, you can get that from FX Med, and the contact info is on a previous slide. And the main ingredients are P5P, or pyridoxal 5-phosphate. It's a gram of ginger, so that's a lot of ginger, and that's one of the issues that I have with this product. For those that have very poor mucosal integrity, they can get some reflux with this, so you have to dose it maybe a little bit more spaced. I like to dose 3 twice a day just for convenience sake. It also has 5-HTP at 50 milligrams. Like I said, I ordered this from FX Med, and if enough people order Motil Pro, then you don't have to order 12 at a time, because that's what it is right now. They don't stock it. You have to do a special order, but I can't keep it on the shelf. It's definitely something. And it's one of those things that when it works amazing. And when it doesn't, you just have to move on and try another product. The bitter herbal that I formulated is Oregon grape, so it's another berberine containing herb, dandelion, gentian, and Bacterial skullcap. I really like this formula. I go through gallons of it, and it really is one of those wonderful uses of herbs in your formula. Is that it does have a little bit of alcohol in it, but the alcohol itself will not feed the SIBO. That should be fine. You're going to use 3 ml before meals in water, and it really stimulates all of the digestive function, not just the migrating motor complex. But again, we don't have enough data to really know if that's working. You'll have to just it's a theoretical prescription, but this was the consensus at the Delphi panel, actually, that bitter herbs definitely have their uses for this purpose. Ayush Trifol is another product that is also used as a prokinetic. It's too soon to let you know how successful I am. Again, it works for some, not for others, so it's good to have more than one product in your arsenal. The key point here is that the most important strategy to turn the the key point really is to turn the migrating motor complex back on. And one is dietary strategy is to stop snacking. We've always told people to keep your blood sugar stable, you need to snack. Well, really you don't. You need to just tell your patient to have 3 meals and make them big if they need to do that. But that's to elicit hunger, and it's that hunger that really stimulates migrating motor complex. And the more you can do that, the more you reset that stuck migrating motor complex. So those that have poor blood sugars, okay, you can give them just small snacks, but generally this is what you want to recommend. The diet protocol is a combination of FODMAPs and SCD. By now, I'm sure all of you have heard of FODMAPs by Monash University. Amazing amount of research has gone into a diet looking at diet of foods that contain particular fibers that are fermentable, but they don't really. They're not that big in SIBO, to be honest. They basically just are purely IBS, but they haven't bridged that gap yet or made that leap that most IBS is actually SIBO. So it's one thing you really want to be aware of is that the diet mainly is FODMAP, but you can't just hand out the FODMAP book because there's a lot of foods that are there or listed there that you can't really recommend. And I'll show you what our new handout looks like in just a minute. SCD stands for specific carbohydrate diet, and that was pioneered or reinvented by Dr. Elaine Gottschall, and she wrote Breaking the Vicious Cycle. It's a great little book to have as a just on your shelf. It's great for inflammatory bowel disease, and it's mainly a grain-free diet. But in a nutshell, the 2 phases of this protocol last about 6 weeks, so a total of 3 months. And phase 1, group 1, what I've done now is rather than everybody going on phase 1 or staying in phase 1 for the entire 6 weeks, because I realized some people after 2 weeks are basically almost completely symptom-free. So those people can actually move into group 2 of phase 1. So this, it might be a little late in the day to get complicated, but basically phase 1 has group 1 and group 2. And everyone starts with group 1, and then if they're doing 80% better, they can move on to group 2. And then group 2 is also known as SIBO moderate diet. Phase 2 is basically those that have stayed in group 1 the entire time can move on to group 2 in the phase 2, and it'll become a lot clearer in a graph on the next slide. And those that had moved into group 2 can now move on to the maintenance diet. So graphically what this looks like is that everyone starts with the SIBO foundation diet, group 1. Those that have improved can move to this level from group 1, can actually move into group 2. And those that are not improving, they're staying in group 1. And then after 6 weeks. Those that have are in group 1 can now move to group 2, and those that were in group 2 can now move on to the SIBO maintenance diet. And what this looks like, I don't know if you can actually see that very well, but this is just a table format of the handout that you can download right after this webinar. You can go to SIBOTest.com and log in and download both the protocol and the diet. But basically, group 1 is the foundation diet. Everyone stays there, and you just best is what I tell people is you just stay there until I talk to you again in 3 weeks. So you start everyone out in group 1. Then after 3 weeks, you reassess. If they're doing really great, move them on to group 2, and just keep them there until you see them again 3 weeks later. And this is just a second page of phase 1. This is the active treatment. And then phase 2 is the maintenance diet. And here we can have a little bit of homemade yogurt, some butter, some cheese, and all the handouts are also going to be how to make yogurt and so forth is going to be added to the practitioner resource section on the website. There's different vegetables that are both in phase 1 and phase 2, and sometimes in some vegetables in phase 2 you can just increase. And again, we see some fruit in phase 2. I actually skipped over that a little too fast, so let's go back to phase 1, where we see really very restricted vegetables, proteins, and fruit. There's actually no fruit other than lemons and lime. They can have meat, fish, poultry, and eggs, pretty much as they want, and then just add the vegetables to it. There's absolutely no grains at all. In phase 2, in group 2, this is after 3 weeks. If they've improved a lot, or perhaps if they've lost too much weight, you can actually test it out. You can give them a little bit of basmati or jasmine only. So none of the glutinous white rice or any of that, but just white basmati or jasmine rice. And then phase 2 again is where we can actually even try a few lentils. So this is all new. We can have brown lentils or red lentils. So this is very different from what we had before. So some of the key points to a successful diet is to really follow it to the T. It's successful only if the patient is not deviating too much. The diet alone can decrease the symptoms but does not treat the underlying cause of SIBO, which is an impaired migrating motor complex or obstruction or non-draining pockets or whatever that may be. And remember to discourage snacking to allow the resetting of the migrating motor complex, and use the SIBO diet handout as a guideline, but adjust to each patient's needs. Just a brief word about the elemental diet, which is an antimicrobial alternative. I have not included that here because I have not been able to source a proper amount, a proper source of plain amino acids. This is not protein powders. Amino acids are actually quite foul tasting, and if you mix that with oil and honey, it's very difficult to get a compliant patient. And Dr. Alison Seebecker, who runs also the SIBO Center in Portland, said, look, it's very difficult to get people to do that, but they could do that instead of antimicrobials. And so watch this space. I will be looking further into that in the future. Just a word for those that can prescribe conventional antibiotics. For diarrhea and constipation or alternating, the typical prescription is rifaximin, 550 milligrams 3 times daily for 2 weeks. And constipation dominant SIBO is rifaximin and neomycin. And the neomycin dose there is, oh, I'm sorry, I missed that. It's 500 milligrams. Please include that right after neomycin, 500 milligrams twice daily for 14 days. So that's a combination prescription. What I will say about that is I have, if I could prescribe rifaximin, I would, and if it wasn't $800 a month, I would, because what I've learned about rifaximin is really quite impressive, that as an antibiotic, it's biosoluble, so it actually penetrates the biofilm in the small intestine. And because it's biosoluble, it doesn't have any of the antibiotic side effects that we see with things like flagyl that are water soluble. So rifaximin is an excellent antibiotic, and we always have, as naturopaths, this sort of instantaneous aversion to antibiotics, but I really changed my mind about that. But the fact is that rifaximin is still, and it would be considered an off-label use for SIBO, and all of my research has found that Medicare does not cover it yet, and it costs about, some doctors prescribe it, but it does cost $800 for 14 days, and it's hard to get people to do that. The other mention that's very worthy of mentioning here is erythromycin as a prokinetic. And we all know erythromycin is overused as an antibiotic, but antibiotic activity of erythromycin really is in the 2,000 milligram range. What they found is that erythromycin at 50 milligrams is actually stimulating motilin release in the small intestine, and therefore resetting the migrating motor complex. So it's really, again, a possibility for those that can prescribe erythromycin or get I have actually had a patient ask for a script and was able to get it for her. 50 milligrams before bed is the dose, and that's certainly, sometimes you just have to gauge how many pills a patient has. That beats 6 capsules of Modal Pro, and she was having a lot of reflux with Modal Pro, so I'm glad to have that prescription for her. The other one is low-dose naltrexone, which gets a lot of attention, not just in the field of SIBO, but I won't mention anything. If you have a question, please just about LDN, just email admin@SIBOTest, and we'll get that answer to you. Now, what I've done with this SIBOTest website is that I'm a practitioner, and I really want to promote other practitioners that are treating SIBO, because there aren't that many people out there that even have heard about SIBO. You'll get patients that know a lot about it because they are the ones suffering from the symptoms, so they will know what to ask for, but a lot of practitioners don't know about SIBO. So my intention was, besides offering online testing, is to actually have a practitioner resource section, which is now there. Everybody that orders tests through the site gets free advertising. You're listed as a SIBO treating practitioner on our site, and we get a lot of we actually get a lot of hits on our site. We actually had an order from Norway, I think, a week ago, so obviously it gets around. But the other thing that is very helpful is the practitioner section. You can get a patient handout. You can just download it, which is the instructions on how to order the test. So you don't have to spend time in your session to explain how to order the test. You just give them the handout and tick the box of which test you want your patient to order, and then the treatment protocols are also there. And also, as soon as you start ordering, you can have all your patient results. You can always look them up in your own admin panel on the site. And I was also going to say that it's a fantastic resource for your patients, because there is a 4-minute video right on the homepage of that test, of SIBOTest.com, where people can just watch and get all the information about what SIBO actually is. And there's also a quiz which can weed out some of your patients from, might not be SIBO. So if they have a very low score, they can tell you that. So it's a good resource, and it continues to be a work in progress, but it's quite up and functional at this stage. So I want to take this time to thank you very, very much for your attention. Let's see if we have any. We actually have some questions, so we will, let's have a look here what we've got. Let's see, just figuring this out. So hang on just a second. Okay, one question is the bloating from SIBO usually in upper, middle, or lower abdomen? Great question. So because there are always anatomical differences, most of the bloating you will have in the upper gut, but that's also where the transverse colon is. So it is very often, it's one of those cases where you have to take the physical symptoms as well as the test results. You can see where SIBO is. So the test will actually tell you where in the small intestine it is. But it can also be, when people say it's after 2 hours, then you really think it's more large intestine, although you cannot completely exclude SIBO just by location of bloating. Okay, another question. Can proton pump inhibitors mask symptoms of SIBO? When client tries to decrease proton pump inhibitor, symptoms of epigastric pain and discomfort arise. Well, the thing with proton pump inhibitors is that as soon as you stop them, excuse me, there is sort of a rebound hyperacidity as the body is trying to adjust all of a sudden to not being suppressed. So you have to always wean off the proton pump inhibitors so that you don't get this kind of rebound as hyperacidity. And so what I do is when somebody comes in with, let's say, Nexium or Somac or any of those, I have them either get a script for half the let's say, with Nexium, it's usually 20 milligrams twice a day or 40 milligrams. So get a 10 milligram script and cut it down, or you just say, okay, have it every other day, or use something like Zantac, which only suppresses stomach acid for up to 70% versus proton pump inhibitors, which is almost 100% blocking of hydrochloric acid production. So you can kind of titrate it down. And sometimes what you have to do is use the demulcents that are contraindicated in SIBO, but you can use them just prior to you starting the SIBO protocol, just so that you can get them off of the medication. Okay, let's see. Now, when symptoms are, this is another question, when symptoms are of diarrhea only, does this rule out damage to the migrating motor complex? I would have thought that a normal migrating motor complex. Great question, but as I've mentioned, the motility of the small intestine is really not linked to the motility of the large intestine. So you can have diarrhea dominant SIBO that still has a migrating motor complex that's paralyzed. So yeah, keep looking for that. There was a question here about a SIBO patient will improve on certain antibiotics. Yes. So what happens, this is often a clue that I didn't include in my basic reintroduction of SIBO, is that one of the clues that a patient may have SIBO is that they said, I've got a lot of IBS symptoms, but then I had sinusitis and I got a course of antibiotics unrelated just for the sinusitis, and lo and behold, my IBS symptoms improved. That's often a symptom or a sign that actually this patient may have SIBO. But because there are other antibiotics that they're not going to be that specific. So, for example, Flagyl or metronidazole is also used for SIBO, but it's so broad spectrum and it's so detrimental to the digestive tract that you're going to end up with a whole host of other issues, and it's not going to kill off everything, versus rifaximin really seems to be very specific for hydrogen production. But our herbal antibiotics, what I can tell you is I definitely see before and after gas production that's very, very successful with herbal antibiotics. Let's see here. Okay, question here about what if a patient has a problem eating rice? Is there anything else they can eat, or can they just eat meat for the pre-test diet? Yes, they can. For sure, they can just do meat, or just have them do a fast day, or bone broth or something. Because if they just eat meat, they may run the risk of just really slowing down transit time, and that can affect, that can result in a very high level of gas, which can indicate poor prepping, and that just means a baseline level that's quite high. But yes, they can do that if they have a problem with rice. They can't really eat anything else. We're investigating quinoa right now, It's a low FODMAP food, but it has been ruled out as a SIBO food, so stay tuned. It's possible that in the future we can use that, but the best bet is just to stay off of grains. But rice is, because of the amylopectin and in basmati and jasmine, is actually a super digestible starch. And so Dr. Pimentel in his cedar cyanide diet has no problem with white rice, but we're a little bit more cautious, so we don't do it until a little bit into the treatment protocol. Another question here, FODMAP diet will suit most SIBO patients. I've had a lot of people come to me that were on FODMAP, had SIBO, and still did not improve. And that's because the FODMAP diet still includes grains. It does include a lot of fruit and other things that I would exclude initially, like zymal milk and those kinds of things. So I think the SIBO diet's a lot stricter actually than the FODMAP diet. Why can broths not be used from the beginning of phase 1? Okay, broths can be used. One thing about that, what we've changed about the broths is that we used to promote a lot of the chicken frames because of the cartilage, because that's where the glycosaminoglycans are and all of the gut healing nutrients that are outlined in the GAPS diet and the SED diet and all of that. But what we found is actually those are mucopolysaccharides. So these are actually saccharides that can potentially feed the bacteria. So we now promote bone broths or meat broths, and that can certainly be used. Many patients with resistant SIBO have heavy metals, which makes treatment impossible. Any comments? Okay, very good question. This actually also means that, I left that out on purpose because biofilm is a bit more of is a potential, but some of the treatments that we do use, and I actually have it in the treatment protocol. When you download the handout, there is a section on biofilm. But one of the things that I find is that, for me, I always treat the gut first. And so if you mean that this person has heavy metals and therefore cannot handle the die-off, I would say definitely promote the detoxification of that. I particularly treat heavy metals with different protocols that it means a very heavy supplement heavy protocol. So I would say I treat the gut before I would even attempt the detoxification of a patient for heavy metals. And sometimes you have to just prioritize as to what's coming first. I certainly have people like that, a lot of people that have multiple chemical sensitivities and so forth, and they tend to improve once they're, you have to go slowly, and sometimes it takes a little bit longer, but I have found it to be quite successful to prioritize the gut over the detox of heavy metals. So really, I can't get to all of the questions. I really want to thank you very, very much for your attendance. I will say that I will answer all of these questions, and we will email the answers around. So just so that for the sake of time, people can get home and get to dinner and so forth. We will send you also out a separate email with the test specials that were promoted on the flyer, so you each get a discount on a lactulose breath test, and you'll also get a certificate of attendance. So thank you very, very much, and I hope to talk to you, each and every one of you, at some point in the future. And all the best with treating SIBO, and please let me know if something is not working, or if you found something that's working really great for you. This is all important. We're sort of in a collaborative right now, and I just I happen to specialize in it, so I can tell you what really works for me, but I'm sure there are products out there that we haven't yet discovered. So I wish you all the best and have a wonderful evening.